welcome everyone to the University of San Francisco School of Management Master of Public Administration program webinar focusing on the pandemic. Specifically, our discussion tonight is titled The Next Phase of the Pandemic, Strategies and Considerations. And really that next phase that we're speaking about is vaccinations. We've been through a year of different sorts of logistical challenges, from ICU beds, ventilators, PPE, personal protective equipment, and now we're in another phase, which is really focused on getting people shots in their arms, sometimes two of them, not just one. In that context, we'll have a discussion with an impressive panel from around the state of California. I'll let them introduce themselves in a moment. In the meantime, I'm Vipul Vyas. I'm the head of the healthcare concentration within the School of Management, and am really happy that we can have these folks discuss this next phase. And I think everyone's COVIDed out a little bit, but we just have to have a little bit more gas in the tank to get through this next phase. So with that, I'll have Adrienne introduce yourself first, then Kosal, then Olivia, and then Miguel. We'll kind of cap us off coming from the state of California. So with that, I'll let Adrienne introduce yourself.
Sure. Hi, good evening, everybody. My name is Adrienne Blaylock. I am the Deputy Director for the San Francisco Department of Emergency Management. And over the last year, I've been very involved in COVID response. From February 2020 until November 2020, I was the leader, the overall commander of our city's Emergency Operations Center, as well as we transitioned into our joint COVID Command Center. And then after November, I shifted into a vaccine role. And I'm currently serving as the overall lead for our high volume, also known as mass vaccination sites in San Francisco.
Hi, I'm Kosal Bo. I am the Executive Director for Medical Affairs and Governance for UCSF. That's a mumble jumble of a lot of different responsibilities at the university, but as it relates to COVID, I am currently one of the 5 incident co-commanders for the hospital's response to COVID. So that oversees many things. Chief among them is vaccine. So I'm actually here to talk to Adrienne about the supply that is not there at UCSF. But I'm looking forward to tonight's discussion.
Thanks.
Hi, everybody. My name is Olivia Tan, and I am currently serving as the Deputy Director for our Health Services Operations within COVID Command for the city. Before, I guess, when it all started in February, I was actually, my home base is at Laguna Honda, and I helped stand up their case investigation program for the skilled nursing facility.
Great. Last but not least, Miguel.
Okay, I was gonna say, wait, am I up? Hello, good evening, everybody. It's great to see some former faculty, some former cohorts, you know, Adrienne and Olivia. It's good seeing you guys. Our class ended in the worst of ways, to be honest. I was so looking forward to graduation, but I'm not gonna lie, I was a little bit happy not to do that commute every Saturday. Currently, I work for the California Office of Emergency Services in Sacramento. There I have 2 roles. My normal steady state job is a Homeland Security Grant Program Manager for an inland region. So I am the point of contact for 14 counties in the central inland region of the state. My additional duties include being activated. Those typically come on 4-week rotations, and the activations last 2 to 4 weeks, or, you know, depending on what's going on. Last year, during the summer or the spring, when COVID was ramping up, I was activated to the State Operations Center, served in the logistics section, eventually worked up to the Deputy for Logistics for the State Operations Center. And in that role, we really just house all the decision makers from the federal, state, and local decision makers like Caltrans and CHP or whatever law enforcement or emergency service might be in the region, and staffing the State Operations Center. It's really just supporting those people who are directing their agencies in the field. And in that role, I would support the response and recovery operations for all of the different disasters, beginning with the COVID, shifting into the civil unrest from the George Floyd protest, over to the wildfire season, and then kind of back to COVID. And presently, I'm actually at the Oakland Coliseum, working the site here, again, with all those federal, local, state, private sector departments and agencies. We're actually administering vaccines. Yesterday was our first day. We did around 700. Today, our goal is 3,000. I think we're at that now. And I'm scheduled to be here until March 10th for the time being.
Nice. So you've had quite a year, sounds like, as
Yes.
has everyone. It sounds
Yeah.
like, yeah. Great. Well, wanted to dive right in because you guys represent a significant amount of expertise and experience, and to be quite literal battlefield exposure in terms of just seeing the front lines of what's been going on and what's worked and what's not worked. And with that, one of the first questions I wanted to ask, and we can go in the order in which we did the introductions, is what would you have wanted to know this time last year, roughly, when this started, that you know now, that you wish you had in your back pocket at that time? What one thing, if it's not one, you can name a couple more. But yeah, having looked at back over the past 12 months, what would that be? I'll let Adrienne
Throwing me
start.
right in, huh?
Yeah.
Okay.
No warm-up questions.
Yeah, that's a warm-up question. Yikes. One thing I wish I knew a year ago, it's probably kind of embarrassing. I personally had a kind of an embarrassing amount of ignorance, I would say, about the varying levels of trust in local government. I think that I was born and raised in San Francisco. I personally always saw the city and county of San Francisco as very trustworthy. And so what I have learned over the last 12 months really is that there's a very wide spectrum of not just trust, but also faith in the local government to be doing everything that it can for its people. And so I think that over the last year, what's been really interesting for me to learn really has been the engagement required in every step of the process to ensure that we're working with our community members, and we are involving them right away at the outset of all of our planning and all of our operations. And so I think that in terms of if I had known that a year ago, we probably would have structured our emergency response operations differently right at the outset. We would have planned a lot more, resourced a lot more, both in terms of funding, equipment, supplies, and people, in investment in community, and building those trusting relationships in members of the community, in our senior centers, in our healthcare partners, and especially the marginalized communities. And because we saw and we continue to see that those are the areas of the city that are hardest hit by the pandemic. So that I think that's well, that wasn't that short, but that's my short answer to the question of, I wish I knew more about the wide range of various levels of trust in local government, so that we could better and more adequately prepare our system of response to be able to tackle that challenge.
As a follow-up to that question, from it, Casal goes, were there particular areas where that trust deficit was more significant than others that you've observed?
Sorry, was that for me or Casal?
Yeah, for you. Sorry, Adrienne.
Okay, no problem.
Yeah.
Yes, and part of it is testing, and part of it's also vaccine. A lot of it has to do with data. and transparency of data. We've been really struggling, especially because what we've been saying is that healthcare doesn't know jurisdictional boundaries, and viruses don't know borders, and so having allocations of resources, including vaccine, tied to a specific county or tied to a specific, even if it's a healthcare provider, a multi-county entity, we aren't able to provide all of the information and the data as transparently as we would like to, because we don't own the data, and it's not ours not only to track, but it's not ours to share. And part of that becomes, unfortunately, interpreted, and justifiably so, as the government's hiding something, or we are not being as transparent as we should be. And so that's been a big that's been a big learning for us. And I think that's a primary example of where it's been difficult.
Got it. Thanks. Chris, I'll let you share your thoughts.
So I guess I will enter two ways, which is one personal and then the other professional. I think personally, I wish I knew the current stock price of Zoom at this point compared to now. The other piece being the duration of this pandemic, in terms of, I would have set up my office here at home much more, much better, because I thought we were going to return back to the offices at some point. But I think professionally, it dovetails with Adrienne's comments, more so on the side that I wish I knew how fragile the system is in terms of public health at all layers of government. I think that it's poorly resourced, and to have a pandemic test the fragility of it all, and to have it reveal where it's failed. So many people, 27 million cases, nearly 500,000 deaths, is an indication of that. And also, I think, as it relates to Adrienne's comments about trust, that the person with a microphone or sitting on that soapbox has such powerful ability to spew whatever they want. And what's been very surprising is the politicization of public health and the detrimental effects of it. We are so committed at UCSF in terms of what we message out, and we have to message it correctly the first time. Because if you mismessage information or it's contrary to what the CDC is saying, we are dead in the waters regarding our workforce trusting anything that comes out of the command center at this point. So we took that extra burden and responsibility that was abdicated by the federal government to have our experts, because UCSF is fully equipped with all sorts of experts in terms of science, in terms of health policy, in terms of very effective legislative folks who interface with both Sacramento and Washington, D.C. to make sure, Nancy Pelosi being, our representative, we had to find alternative channels to get the science out, to get the information out. And I wish we knew that well in advance of this, and we were building the plane as we were flying it. So yeah, I think those are the primary things that I wish I knew.
Yeah, so it sounds like it's the ambient political support wasn't what you thought it would be. And you're surprised I guess the degree and the speed at which a pandemic, which would seemingly be a apolitical event, became more political than previously.
Yeah, I wasn't here for the 1918 flu pandemic, but the degree of difficulty to respond to a pandemic within itself is difficult enough. And then you add in the back handspring somersault to this to really make it difficult. Just was something that we didn't anticipate. And to Adrienne's point about data, like, UCSF is all about, everyone's all about data, and to have that completely disarmed from the process, we were shooting without aiming at this point, because that's what we needed to run this effectively.
Interesting enough, Miguel, the one thing that people may note is that there was an anti-masker league in San Francisco in 1919. So some of the same things that are playing out now played out back then, interestingly enough. But the idea of masks are not novel. For those listening that may or may not know, George Washington himself mandated masks in Philadelphia in the late 1700s when there's a yellow fever outbreak. Yellow fever spread by mosquitoes, so they didn't really do any good, but still the notion was there that this is something we have to do collectively in order to be able to respond effectively to something that is a broad social problem. So yeah, I think that's really interesting how this particular pandemic, with all the science, all the advancements that we have in place, still fell prey to the fears that can be weaponized in society. So thanks for that. Olivia, what are your thoughts in terms of things you wish you knew a year ago that would have better equipped you had they been in your back pocket?
Yeah, I think about this in terms of internal operations for COVID Command. I think the biggest thing for me is defining what a disaster service worker really is, because a lot of times folks, they sign the paper, we're all DSWs, right? But what does that really mean? And especially when people think of emergencies, we think of earthquakes, we think of things that are not year long. And so how we prioritize and organize our staff and resources is critical. And I think that was one of the biggest struggle that we're still struggling with, is how do we work with our CDPH folks? How do we work with our volunteers? How do we work with our DSWs to make sure that everything's happening in the priority that it's supposed to be in? And I think if we would have known, I mean, we should have known, right? Because our HR isn't always the fastest, but how do we manage and create a more flexible environment for our staff to work in? And I think creating expectations, and part of it is really the change management piece, being able to work with your staff, communicate with them what the priority for the department and the city is now, is I think the biggest thing for me, because I have to be honest, when I was a DSW, I signed the paper and I'm a DSW now. But what does that really mean? I've been in this role for about 10 months now. And so it's not a short-term gig. But for me, at least career-wise, it's definitely been a great opportunity. Everybody sees it from a different perspective. It might be an opportunity. It might be something that they don't want to do. But I think, where can we meet folks where they're at to really be able to push that resource of staffing up?
And for the benefit of listeners, do you mind spelling out naming out the acronym DSW?
Yes, so DSW is just disaster service worker. So any city and county folks, when you sign up to, whatever role you're in, you also sign up to be a DSW. So whenever there's a city emergency, you are called into action.
And I think on that front, I read, Olivia, that the city librarians became contact tracers and meal delivery.
Yep.
And logistic folks that were folks were housed, or homeless folks were housed in different hotels. So they're went from shelving books and processing reference materials to moving to handling meal distribution and contact tracing. So that's, I guess, an example of a fairly dramatic DSW designation, where they're put into work right away and doing something that's pretty different than they maybe have traditionally been doing as a city employee. Yeah,
and I think that's one of the biggest things that the city has been able to do, is finding flexibility within their staff. It's not so what classification you're in, but what skills do you bring to your job that we can repurpose to fill a need in another area.
That's fascinating. It seems like everyone stepped up.
Yeah.
So that's great. And then Miguel, speaking from a state perspective, what did you wish you knew a year ago?
If I had a genie and he was granting wishes, I would ask him, well, first let me say it like this. I think currently we're doing, not only in the state, but the country, we're doing a little bit more of a balanced approach to this. Are we open, are we closed? And when we began, it was full stop, full close, stay home. And in time, like the way we're delivering the vaccines, there's a target audience. There's a specific demographic that's getting to the front of the line because they need the protection most. They are most vulnerable to this pandemic. So if we had a better understanding of who does this affect the most and how do we support them, I think that would have been great. But you know, how do you do that other than experiencing? How do you do that other than actually just going through the process, I guess? Let me see. I had a
Yeah, it's true. I mean, I think experience is a painful but probably the most effective teacher.
yeah. So I just
Um,
yeah, I just think if we had a little bit more information or knowledge as to who should we really be focusing on protecting, I think that would be my wish. Yeah, if we could have started with that instead of, you know, let it take its course and just reveal itself. You know, if I could have the answers to the test, that's the one I'd want.
Makes sense. Now, another round of questions I'd like you guys to explore is from a program perspective, what should we be talking about in our program right now to students that would best situate them to do the work you're doing? You know, so instead of what would you like to have known a year ago, it's what would you like to have explored programmatically as, you know, part of the School of Management or Master Public Administration program that would have said, you know, that would have really helped me. Um, and even things that you did learn that you found you could lean into during this crisis that you were exposed to when you were here. I'll let Adrienne start from the top again.
Sure. So kind of building off my previous comments, I think that we talked a little bit about the social determinants of health in our program, but really leaning into that hard. There's been a major equity component to everything that we're doing in San Francisco. And being able to the point where we at the Department of Emergency Management are planning on adjusting our overall program and our overall response mechanisms for the incident command system to start including equity officers in all of our organizations, to include equity components in all of our planning and operations, and really focusing on that community benefits and support lens in everything that we do. And so I think that the social determinants of health and understanding how emergencies, whether they be pandemics or earthquakes or tsunamis or whatever they are, they will exacerbate existing inequalities. And so really leaning into the importance of understanding those inequalities, especially in San Francisco. I mean, we're talking about USF, but within a defined, county or what it is, to really explore that and unpack that. And it's messy and it's complicated and it's hard, but that's the only way to make things work. And that's the only way to have the best impact that you can possibly have for the people who need it most, is to understand from the get-go. And so I think that for a pandemic, conveniently the social determinants of health are really important to lean into, but it's also really helpful to have that as just your overall context for operating in any emergency that you could have in San Francisco.
And for the benefit of those who don't know what social determinants of health are, they're essentially those things outside of the traditional medical system, such as access to transportation, employment, food security, et cetera, that affects someone's life and lifestyle, which then therefore downstream affects their health. And those things have probably, yeah.
Yeah, and so some of the ways that we've been working on that is by working what we call wraparound services. And so when we're giving someone a COVID-19 test at a community clinic, we will also give them flyers that show where they can best access better housing, or we will co-locate it with a food bank, or we will, we'll create these wraparound services to make sure that when they're going somewhere, we are then able to provide as many resources as possible. And we cater those resources depending on what the location is and depending on the target population in that community. And so understanding those social determinants of health are help us to ensure that we are bridging any gap, or at least doing everything we can to make it that much closer.
Makes sense. I'll let you answer the question next.
Yeah, so everything Adrienne said, underscored, bolded, exclamation point. I mean, it is such, I think this answer could answer a lot of the questions, which is the healthcare disparities has been eye-opening. This is such an area of focus for UCSF as a whole.
This goes back to the fragility comment you made before.
Oh yeah, there's some, I mean, this is all intersecting. I think in terms of a class that Rich should teach, it should just be 2020 WTF. That's all it should be called. Because the intersection of the pandemic with racial injustice has been revealing. I mean, vaccine distribution, 3% of Black African-American population in San Francisco has received it versus 35%. One weekend was working at the City College Vaccine Distribution Center on behalf of the city, and you could tell that the hundreds of cars that were coming through were 95% Caucasian. And here I am sitting with the doctors trying to figure out how to better message or to target the right population. So we had to then find the population of San Francisco and then get their zip codes and then target information that way to help the city as well. But I think just to provide a different answer to this, I think that there's a real case study here in terms of what Rich taught me about the hollow state here. I think that you have pros and cons of what worked and what didn't work. Right, you know, President Trump was selective in his use of the Defense Production Act. Right, he only enacted it when it was time to get ventilators and get GM involved, and in that process, the federal government was profiting from that arrangement. I believe that's what I recall from all this, but failed to do this for PPE. You know, the vaccine distribution. He had the Department of Defense be responsible for distribution, which they have no expertise in doing. So you would think that this is the time that they would delegate that responsibility to folks. At least I think that that's what Pfizer did, because they were the first ones to roll out. The DoD was doing it, and the Moderna was using some private organization to do distribution. So I think that there's a real opportunity to understand the pros and cons of when to effectively delegate responsibility in the federal government or any other government, understanding that that the selectivity of when to do it, I don't know. It should be studied. How about that? Because I think
what you're saying is that there's times when the federal government is going to be better at something than the private sector or even other entities.
Right.
And being able to discern when collective action is better than sort of delegated action is important. And there's a reason why we leave it to governments at different levels to manage things like roads, the military, etc., because they are structurally set up in what is probably what I'd call a natural monopoly to do that, to execute on that. Now, I think what was interesting is you mentioned that so few African Americans were getting the vaccine just from what you could observe. And this is despite the fact that African Americans are taking the brunt of the suffering in this pandemic. I believe there's a shocking statistic that 1 out of every 1,000 African Americans has perished from this disease. So, I mean, that's just a shocking number.
Yeah.
Yeah, the vaccination rates are very low.
The Latinx community in San Francisco has definitely bear a significant brunt of the disease. Some of these, yeah, Vipul, everything you said, so cut my answer out from the video. Your voice over mine, that's the answer.
I think you get the credibility. I don't. But no, I appreciate that. And with that, Olivia, would you like to answer?
Yeah, I think I appreciate Adrienne and Casal's answer to that. Talking about health disparities, I think of folks with a health background within DPH, and I think what would be useful for the MPA program is really how do we do cross-sectional work to break down silos? Because I find it very interesting that even within the Department of Public Health, we have separate divisions, and even within those, we're very siloed. And so what does cross-sectional work look like? How can we utilize SMEs, subject matter experts, to make sure that we're looking at data to make decisions? And then, who has the last say? Because I think something very interesting is that DPH folks, although we practice ICS, incident command structure, I see Adrienne laughing. It's because we don't use it until we need it, which is where we are now. And so, being able to practice and utilize those muscles that we don't use often, I think is very critical. So yeah, how to better improve cross-sectional work across the different departments and even across different organizations and CBOs that we have.
Olivia, does that surprise you, given that California and San Francisco has its unique share of natural disasters and issues, from earthquakes, wildfires, all of which, at least we've suffered from wildfires. Most recently, knock on wood, the earthquakes don't come anytime soon. But would you have assumed that we had more of a incident command competency than we did? I mean, I guess the last time we went through this was 100 years ago, but we've lost the notes from that.
Yeah, no, it's still definitely ICS, but I think how we utilize the ICS structure is a bit different now. Just thinking about how long we've been in this pandemic, who's going to be taking control and what leadership and what role. I think that has been very interesting to just see the rotation, because we do realize that, DPH needs to focus on health services, and then Adrienne's department, they have to focus on the more large scale, what does the city look like? But I think there's definitely been kind of this dancing, you can say, on our end to figure out, what needs to get done. And so really being able to identify the cross-sectional work and how we can work together as a team to do that.
Good point.
And if you don't mind me just jumping in
sure.
for a quick second, try to restore what credibility I have. I think it's important to note that one thing that I've learned is the difference between what we call ICS and what DPH calls HICS, which is the hospital version of ICS, and again, Incident Command System. And the San Francisco trains on ICS all the time. It is what the fire department uses in every single fire. It is what the Department of Emergency Management uses in every single real event, planned event, special event, beta breakers, Pride, New Year's Eve, things like that. But the disparity between the hospital version of that and the kind of real world emergency management version of that is a lot bigger than we knew and than we recognized. And so we've spent a lot of time bridging those together and making sure that the overall incident management world actually fits within the incident management world on the health end.
Makes sense. And before I let Miguel continue, is one thing I do have to just comment on is San Francisco, compared to its brethren, comparably dense cities, has not suffered as badly from the pandemic. And that's a testament to people on this call and in the city in general. It didn't turn into New York. Not that New York did anything wrong. It just, I think, was unlucky in some ways. But San Francisco quickly learned, and San Francisco did not become Los Angeles, or did not become New York, despite being a fairly dense city, and I think the second densest city in the country. So I think that's a testament to the response that people easily overlook. With that, Miguel, from a state perspective, what are your thoughts on sort of the same topic of what we should be thinking about more in the program?
Yeah, I'm just touching off what you said. Kudos to the city of San Francisco. I mean, they were the first to shut down in the nation. I'm sure that wasn't an easy choice, and to your point, it turned out to be the right one. So Maryland and Reed, shout out. I would say for the program, for the students, if you could develop your own personal skills and abilities on how to successfully navigate ambiguity and being able to do so with a sense of command presence. So we're out here at the vaccine site. There's no playbook on how to turn in the Oakland Coliseum into a mass vaccination site. There's no process that we've done or practiced or rehearsed to bring all of these different agencies together. That's for you to figure out. And you're going to do that by teaching yourself how to be comfortable in uncomfortable scenarios and learning how to make the right decisions, right? Develop your own approach that you can tailor your process in a way that's genuine and effective. And what's worked for me is, you try to measure your results against the purpose of your goals. If you don't establish a goal, you have nothing to measure, like, hey, are we on the track or not? Is this the right way or not? And you have to be able to reflect on your progress with being objective on the things that you're working on and search for opportunities and ways to improve the areas of your operation. And a simple kind of management checklist, I guess I just run in my own head is, assess the situation, analyze what's happening compared to what needs to happen, strategize on ways to make that happen, and implement your plan. Once you implement it, assess and reflect and measure that progress against your goals. And you're just constantly going to repeat that process and tailor your approach so that you are achieving the goals you've established, essentially.
That makes complete sense. One of the interesting things on that front, Miguel, is we're doing a lot more case study work, which is essentially presenting a general problem and saying, here's the situation, and what would you do? And there's no right answer. It's really your thought process. And there are no right answers in the world, and to your point, it's the results that ultimately tell you whether the activity you chose to do yielded the accomplishment you were going for. In the classroom, it's uncomfortable. People don't know what textbook do I look to? What pages do I read? Google it, find out, be resourceful, call the call center of the company we're discussing in class and talk to the agent, walk into the store if you have to. Can't do that these days. But I'd rather folks be uncomfortable in the classroom than uncomfortable on the job. So they get that experience. No, I appreciate that answer. Adrienne sort of alluded to this earlier. In my next question, I'm skipping around a little bit from our pre-formatted questions, is now that we're getting to the point where vaccines are rolling out, and to Cosal's point, I'm not sure, and I should look this up, if the War Powers Act was invoked for vaccine manufacturing. But at some point, similar to PPE, similar to ventilators, we'll get past the supply issue. We'll get past the logistics issue. Then it's going to become a compliance and engagement issue of, can we get people to do the things that are right for them individually and collectively and believe that? So Adrienne, I'll let you start with that, because I think that's going to be something people don't see right now, is this issue where it's not about, hey, I don't have enough vaccines. We'll get the vaccines, I believe, and we'll get them in the arms of everyone who already wants to get them. Excuse me. And then it's going to be, how do we convince the rest of the folks that need to get it to do it? Because if we have a huge pool of people who don't have the vaccine, that's going to create a pool in which new variants can emerge that can affect everyone negatively, and we won't have that herd immunity necessary to really fully open the economy. So Adrienne, I'll let you start with your thoughts on that subject.
Yeah, absolutely. Thank you. I think that goes back to my initial comment about trust in government, and not just local government, but trust in all levels of government, and how we have to invest in our community relationships in order to better build that trust. In terms of overall, we are counting down the days until supply is no longer the limiting factor in our vaccine distribution plans. And I am getting, a little bit nervous, quite frankly, about when we encounter not just the vaccine resistance, but the vaccine kind of choosiness, if you will. And, we were very fortunate that Pfizer and Moderna are essentially the same efficacy, 94, 95% between those two. And they're both equally effective across all racial groups, across all ethnic groups and ages. But what's really difficult is they're the two dose shots, right? It's a 2-dose vaccine, which logistically is so difficult. And you have to get the same brand. And then we're introducing quite possibly and hopefully the Johnson & Johnson version, which is a 1-dose shot, but the efficacy is lower. And it's what I worry about, vaccine hesitancy and kind of resistance down the road is really focused on people. I don't want this vaccine, I want that vaccine. And
I can see that myself doing that, actually.
Yeah,
Sorry.
and granted, like I get that, but it's on us as the government and it's on the healthcare providers to educate people to understand the intricacies, which are so difficult, of the efficacy and of the trials. And like Pfizer and Moderna's trials, even from each other, were testing for slightly different criteria. Like Pfizer was counting cases of COVID 7 days after their second dose. Moderna was counting cases of COVID 14 days after their second dose. So even the efficacy is measured differently because it's a different level of antibodies that you build up after your second dose. And both of those trials tested only for symptomatic infections. So they weren't testing for asymptomatic infections. Then you get the Johnson & Johnson vaccine, and their trials are working on, it's focused more on the severity of getting COVID. And the Johnson & Johnson, by contrast, it's the 1 shot, but it's also, it's testing and it's trying to prevent the moderate to severe COVID cases. And they define that as, a symptom plus a positive test. And that's beginning from, I think it's 2 to 4 weeks after you get your dose. So when we're comparing them, it's really comparing apples to oranges, even between Pfizer and Moderna. And so I really worry about vaccine hesitancy because we're so focused on data and we're so focused on, oh, this one's better than that one. And instead, we should be focused on, we got to get something in your arm because this pandemic is real and it's taking people out. And we need to make sure we are protecting you the best way that we can as quickly as possible. And so I think that's what I'm most worried about is the lack of, not just the lack of education, but I think it's really hard to understand these things. And it's hard to kind of convince someone to possibly take something that they feel is less effective than what their neighbor got. And that's only because they were lower on the priority list, and that's not fair. So it all comes back to trusting government, equity, and being able to communicate effectively and transparency.
And from a communication perspective, those are very complex concepts to communicate, and especially in a bite-sized manner, almost virtually impossible. And that's not to say like what's the difference between an mRNA vaccine versus a human adenovirus vaccine, which maybe people shouldn't even bother putting their heads. We haven't talked about Sputnik 5, the Russian vaccine, which has apparently knock your socks off type of efficacy, but we don't know. So yeah, there's a lot of things out there. And AstraZeneca, there's more vaccines coming beyond the 2 that are dominant at the moment as well. So that's a great point. Kasal, you answer the same question.
Yeah, Bipul, I think it's, how do you take science and what you just said about the mRNA technology and the adenovirus? How do you break that down into layman's terms for folks?
You lost me at adenovirus. That's probably what most people say.
The Johnson & Johnson one, which is, we struggle with getting medical terminology down to what is fifth grade level. Quick, easy information that folks all across cultural boundaries can understand it. And so how do you take science, mRNA technology versus the adenovirus, the J&J one, to explain what Adrienne just said in terms of the efficacy differences between both, right? mRNA vaccine is new technology. We have never seen it in a vaccine ever, right? And so there's a resistance there because people are like, you go first, type of thing. But
if you're alive in a year, maybe I'll think about it, kind of thing.
But you know, there are some evolutionary biologists who are like, what's going to happen here? Because we don't know how humans are going to, in the long run, respond to this. Not to mismessage any type of fear, but it then bolsters the J&J vaccine, which is using typical vaccine technology to get 67% efficacy. And to Adrienne's point, it was studying mortality and severity level. And if the name of the game in COVID is to survive, I would actually want the J&J jab before all the two thing, you know, and just because it's easier at this point. So, you know, how do we get that information that someone like me who can fake the funk for 5 minutes and explain vaccine technology, but to my friends and my family members who need it broken down in a way for them, like, oh, I should get the J&J one. I get it. 67% is not bad. And you compare it to the flu vaccine, which is typically 50 to 60%, and we all get it.
Some years 10% even.
So I think we also need to reach a point where, combined with all 27 million people who have been infected and have survived, well, not survived, but 27 million who have been infected, compounded with those who have been vaccinated, does our government, the society, accept herd immunity where 100 million people are not going to be vaccinated? Because herd immunity is what, 70%, you have 30%, that's 100 million people, over 100 million people who may not have it. And do we accept that as an acceptable threshold to start opening up the economy?
Right.
Yeah.
Because even at a 0.7% case mortality rate, that's 700,000 people out of that 100 million would perish if they aren't vaccinated. Assuming certain things about the demographics of those 100 million. Yeah.
I mean, we as a society accept flu deaths at a certain level, right? I mean, and I don't know what the flu deaths are, but are we going
30
to
to 60,000 a year?
Yeah, are we going to reach this we're going to have high deaths at the beginning, but at some point, some gradual tipping off that is now the acceptable rate of COVID deaths every year, because it's here to stay.
Right, makes sense. Olivia, your thoughts on the same topic?
I guess when I think about this question, I don't necessarily think about the resistance, because I want to reiterate the point that Adrienne had brought up of really being able to get, at this point, any shots into everybody's arms. And I think one of the biggest points for me is when we look at the data, we really look at how it's affecting people of color, and looking at the history of Black African Americans and medicine, I think is a big thing that we need to repair as a community. To be able to work with our CBOs and also our hospital organizations across the Bay Area to be able to effectively communicate the efficacy of these different shots, whichever one it may be. But I think when I think of resistance, I really think of that first, is how do we target the most vulnerable population and those most at risk.
Makes sense. Meaning the people who likely need it most because they're going to be impacted the most by the pandemic. Makes sense. And Miguel, since you're actually at a vaccine location at the moment, you may have some real-time insights on this topic.
It's been a very rewarding experience talking to the members of the community here at the front gate. Everybody is very eager. Well, everyone that's come to the gate is very eager to get in the gate and get the shot. And like everybody else, I am corona'd out. I'm ready for the stores to open. I'm ready to go to a restaurant. I'm ready to eat inside. I'm ready to do all of those things. And to kind of calm the general public's, fears from this pandemic is the vaccine. That's everybody's just kind of waiting, like, okay, this is out. They're going to develop the vaccine. We're going to have it. Everything's going to get better. But like Kosal said, I don't know if the vaccines will completely eradicate this. I think, like Kosal said, there will be a certain level of unfortunate mortalities each year. And at what level, what's that magic number? When are we going to feel confident and comfortable with, hey, now we can get back to, living our lives as we knew before this pandemic. But here at this site, I am I'm interested in supporting vaccine delivery for anybody who shows up and wants one. We're not able to accept everybody as they show up. We just have a different process that we're trying to do. I know that we're going to be here for 8 weeks. We have a lease here for 6 months. So as long as the federal government can continue the supply of the vials, we'll be here supporting the community, supporting the member state of California, and doing our part to reopen, and get things back to how we want them to be, because I don't know anybody who wants things to be this way, and like I'll just say again, I think vaccines is the quickest route in order for us to get there.
Makes sense. And I want to be respectful of time. In the 5 minutes we have remaining, following on what Miguel said in terms of, Miguel, you're working in the trenches and the logistics, getting shots in people's arms, which is fantastic. And it feels like things are changing in terms of you're having this large center where you can do 3,000 shots a day. So it feels like the momentum is building.
Yes, and we'll eventually be at 6,000. Tomorrow we hope to do 4, the next day 5. And by the end of the week, we want to be at 6,000 and doing 6,000 per day.
Yeah, and then I can see that the exponential or at least linear growth that you're describing. One of the things I have to just comment on is that, on this call from the University of San Francisco program, we've got folks that are leading the charge across the state of California. You can really feel it, and really in the trenches and in positions of leadership. And I think that's amazing.